who is a pediatric emergency medicine doctor who is doing a fellowship on that topic and in global health. So he's been spending much of the last year in Moshi, Tanzania, away from his normal home at Cincinnati Children's Hospital. Uh, and he's working with Liz Keating and Catherine Staten uh, to look at transportation or ambulance care for pediatric injury patients there in Tanzania. So he is hoping to get some feedback today. I'm sure he'll explain that. Um, but without further ado, I will turn it over to Dr. Seegers. Welcome.
Hey, everybody, and thank you. I'm going to go ahead and share my slides. Are you all seeing my screen now?
Yes, and we'll just breeze
Yeah.
past your very busy desktop.
No. Oh,
Doesn't
yeah,
give
that is
anybody
on my
anxiety.
and when it gets messy enough, you just start to neglect it, and that's kind of the phase that I'm in. But yeah, hey, everybody, I'm Mac. I'm going to leave my screen off. The internet's been misbehaving a little bit here. So if things start to get choppy, maybe we can just turn other screens off. We are totally fine for now, but internet's been misbehaving a bit. Like Ashley said, I'm a Fogarty Fellow. I'm in Moshi, and I'm looking at ambulance care of injured children that has expanded to adults as well. So I want to run through all of my slides. I have a lot of preliminary data, and overall, I'm trying to get very big picture feedback for kind of defining outcomes. How do I compartmentalize my findings into papers, that sort of thing. So I've got red flags beside everything that I specifically would love to get feedback for during this session. And what I'd love to do is kind of have a bit of a conversation. So instead of me talking for 20 minutes and then stopping at the end, we can kind of stop wherever there are red flags and get some feedback in real time. Many of you have way more experience in research than I do. And so I'm hoping that kind of my clinical background with all of your scientific research backgrounds together, we can figure out how this makes sense to do, and kind of thinking from the perspective of a reviewer or a reader, that sort of thing. So there are two papers. I'm only going to talk about one of them today, just for sake of time, and then you'll see me again in about a month or so, and we can talk about the next one. But so the first bullet, I'm planting these flags at the beginning. I do not want to talk about these now, but we can talk about them again at the end. But as we're reading or going through the different slides, I would love for you to be thinking about these things because I will ask the same question again at the end. So first, I have adult data and PEDS data. It is the same data, but coming from two different registries, a pediatric one and an adult one. There are some kind of subtle differences, but the data is essentially identical, and the way that it's collected is very much the same. Again, compartmentalization of papers. The big question being, am I trying to squeeze too much into one paper? And then lastly, if anybody thinks this stuff is interesting and you just want to talk one-on-one, sometimes that can be a lot more, you can get a lot more detailed feedback than trying to do this in a large setting. All right, so again, we're starting with paper 2. The topic of this paper is emergency assessment and resource capacity. A very, very brief info, the things that I think you need to know for this conversation. EMS systems are often divided into what is called formal and informal EMS systems. Formal is what we're used to in Durham, for example, where if you have an injury, you can call a number like 911. An ambulance will be dispatched with a paramedic or something similar who's been trained on an ambulance. They can pick you up and take you where you need to go. Informal just means those elements are not there. And so what that means in lots of sub-Saharan Africa, including Tanzania, is that really if I get injured, then I need to find my own way to get to a health center. It's often just by a good Samaritan who picks you up. And then the ambulances really function for inter-facility transport. So you get yourself to a health center, and then you can get on an ambulance that will take you up the hierarchy of different health centers until you get wherever you need to go. And then because there aren't established ambulance care, There are no paramedics, for example. So I have this term MEP, medical escort personnel. That is a person, usually a nurse, who's kind of plucked from their duty and asked to accompany a patient from one center to the other. Maybe they've been on an ambulance, maybe they haven't, maybe they've cared for trauma patients, maybe they haven't. But MEP, just think paramedic is the person who's accompanying an injured patient on the ambulance. And then data collection, as I mentioned, there are two different quantitative registries that includes a questionnaire to the medical escorts when they arrive. And then the only other last thing I think you need to know is that the RAs then look at the resources on the ambulance. They always try to go in and verify with their own eyes what's on the ambulance. Sometimes that's not possible. For example, if the medical escort says, hey, I really need to get back, there are sick patients at the other facility, we never interfere with care, but that's probably the main reason why it is not verified with their own eyes sometimes. All right, so this is paper 2. I've looked at the scope of this so many times, and this is what I've come up with so far. So for the scope, I'm just going to read this. Effective pre-hospital trauma interventions depend on 2 upstream determinants. 1, accurate recognition of physiologic derangements through patient assessment. And then 2, availability of essential emergency resources. So what that means essentially is if we want to design interventions, we need to already have some capacity to, 1, assess that something's wrong with the patient, and then 2, we need the resources to do something about it. So the sections that I have kind of laid out for this paper, section 1 is strictly descriptive. What is happening during transport? To my knowledge, there has never been any paper ever written describing what happens to trauma patients in informal EMS systems. I saw a review from, I think, 5 years ago, and they summarized, I think it was 5 or 6 papers, but all of those were from formal EMS settings. So we don't really know what's happening in these informal EMS settings, despite the fact that it's the large majority of the population of sub-Saharan Africa who's serviced by them. So 1 is describing what's happening. 2 is recognition of the problem. Are the assessments adequate? We'll talk about that more. So what are we doing to assess if the patient needs help, for example? And then lastly, section 3 is our capacity to respond. Are the resources on the ambulance adequate? So I'm planting another flag here. I think it'll make more sense to discuss it once we have a little bit more clarity on what I'm talking about here. But should this assessment and resources actually be 2 different papers? This is the feedback that I've gotten. Instead of squishing them all into one, maybe they're 2 distinct topics enough that each have their own multivariable model. Maybe these should be 2 different papers. So let's talk about it a little bit more. That's another thing that I'd love to keep in mind and get your feedback on. All right, so I mentioned these 3 different sections, 1, 2, 3. Now I'm going to go through each section. Section 1 is presenting the raw data. So again, right now I have it divided into pediatric and adult. My feeling is that it probably actually makes sense to combine them, but everything I'm going to show you is with the data separated so that you can see with your own eyes whether you think it makes sense to keep them together or divide them. So just as an example, at the top, I don't think you can see my mouse, but at the top, for example, pediatrics, if you look at the very top figure, you'll see SpO2 for all patients is measured about half the time, 50%. And for severe patients, it's measured 75% of the time, for example. Under that, you can see different physical exam elements. So you can see, for example, their patient's perfusion is assessed just under 50% of the time for all patients and just over 50% of the time for severe patients. I have my definition of severe there at the top right. Any patient who is intubated at any point during the course, they received a blood transfusion at any point during the course, their GCS was measured at 8 or below at any point during their course, or they were admitted to KCMC ICU, or they died at KCMC. I chose this rather than some of the other standards for defining severe injuries. That's a bit of a long conversation, and I'm planning to talk more offline with some people who know more about it than I do. But I do want to just pause for one moment can you see all those questions that I have at the bottom, or is the window in the way? Can you see them?
On the right bottom side with the flag, yeah, we can see those.
Correct. Yeah.
Like one,
Okay.
two,
All right.
three.
Yeah, perfect. Okay. So question one, is it useful to show severe patients? So I have in this figure to the left, I have I should probably switch the colors, but all patients are the ones in red, and then the most severe ones are the ones in green. For me, it's kind of interesting to, you know, we might want to do something different if this is a patient who has a broken arm versus someone who's bleeding out and about to die. So for me, there is some important context to knowing, um, is this a severe patient or is it not? The reason why I ask, for the multivariable models that I'm planning to do at the end of all this, severity is just one of maybe 8 or so variables. And so it does seem a bit strange to kind of isolate that variable at expense of all the others, just because, I think it's interesting. So I'm curious to get all of your feedback as to whether you think I should include this delineation with severe versus all. Number two, my definition of severe, if anyone has any feedback on that. I know there is some precedent for using definitions like this one, but if anyone has more experience than I do, would be glad to hear your feedback. And then lastly, I've included a bar plot here. I think it's kind of interesting to look at visually. But if this is my outcome for section one, then maybe I need to actually show the numbers themselves, which could be a table, or maybe even I could include the figure and then have a table in the appendix or something. So as a reader, what's the best way to actually display that information? All right, so those are my 3 questions for this slide. I'm going to pause for a minute and see if anyone has any feedback.
Awesome. Thanks, Mac. 2 things I wanted to say. First is we can see your mouse when you move it, so that's helpful.
Good.
And uh, I was going to raise the question of numbers before you mentioned it because I want to know, even just giving you the feedback here, if you can remind us ballpark, what are your total numbers? Because I know you might not be doing any statistical like hypothesis testing, but it's still helpful to understand how meaningful some of these differences are, right? Because if you had a very small number, it could just be totally random
Mm-hmm.
that you're having these differences. So
Right.
can you remind us, like, what is your sample size?
Currently, there are 75 pediatric patients and 207 adult patients. This data that you're seeing right now is not quite that high, but that's the ballpark.
Sure. Okay, so it's modest but not huge. Relative, I mean, still relatively small, I would say, for this for the kind of parsing that we're doing. So but that's helpful to know. Regarding the question of stratifying the severity, I find it interesting too. But of course, I think if you were going to put that on the paper, you'd probably need to back it up with some literature. Like, I could imagine there might be some hypothesizing about it's important because if we are going to roll out, better pre-hospital systems, if we were going to put a focus on severe patients, for example, that would make total sense to be assessing what's happening with severe versus everybody. So that's one thing. It's interesting too that you, instead of doing severe versus not severe, you do severe versus all. It might be interesting to tease them out completely, in my opinion. But again, I would look at what's happening in the literature. As far as the table versus bar plot, I don't have anything to add there. I'd love to hear from some people who are more well-read and smarter than me about the questions, though. So please, if others have opinions, go ahead and share. You can share in the chat or unmute.
I'm not actually seeing chat, so if someone does chat, then just let me know. Oh wait, never mind. I can see it.
Eduardo has some input, and for those who don't know, Eduardo heads up the emergency medical system in a large city in Brazil. So I'm sure you have some helpful input.
How about that? That's great.
Hi, Dr. Segers. Good to meet you. Congratulations for your great work. I think I have great ideas, and maybe we could chat later and exchange some experience. But specifically regarding what you said about severe patients, maybe you could think about more validated instruments such as Revive Trauma Scale. You have more than enough of clinical data to use for those, and you could stratify these patients instead of just comparing them severe versus non-severe patients. And what I actually talked about, which is your sample size, is really important because if you decide to divide these patients from uh, adults versus children, well, I'm thinking about my reality here where our pediatric patients are less than 5% of our EMS. So it would be maybe a kind of a problem when you come to statistical analysis, consider the small numbers. So maybe thinking about assessing them and providing means of adequate transport for the whole population instead of splitting them into two separate groups, like one paper thinking of all this pre-hospital instead of just separating them could be more interesting from a statistical point of view. But I'm happy to talk to you later in case you need to hear more. Maybe I might have more to contribute.
That sounds great. Yeah, I will definitely get your contact, and I would love to follow up and have a longer conversation. That'd be great. Yeah.
There's
Should
a
I
note in the
continue?
chat. I think we have a couple more folks that want to comment, and the Ton asked about is the question regarding the data, is it availability of vital sign data? Like, was it taken, or yes or no? Is that what you're looking at, like in the first?
Yes. Thank you for
Okay.
clarifying that. But yes, was it done or was it not done?
Okay. And then I think Joao was going to add something. Yeah.
Yeah, I was just gonna add here too the question about the severity. I can't really touch on that. I would talk to the clinicians, but on the visuals and the usefulness of this. I think the first question is what are you trying to get at from this visual? It didn't come clear to me. You're comparing severe to all patients, which would include the severes on them. And so are you trying to show which ones are more, happen more with severe patients? And therefore they are more relevant, or something that this, so what are you trying to show in the end with the figure? Like, what is this one hypothesis, one take home message?
I guess the thing is really the gap between 100% and whatever, how often it's not done is really, I guess, the thing that's interesting to me. And so like for a severe patient who's, who ended up going to the ICU or something, the fact that their heart rate is checked less than half of the time is pretty astounding to me. That's not to say that it couldn't be told just as well from a table. I guess I think more visually, and so this is how it made sense for me to look at it, but others will think differently, and that's why I want to bring it to the community.
Great questions, great points. We can keep sharing in the chat, but Joao, if you have another comment, feel free. But otherwise, I think maybe we go forward to get more.
Yeah, no, I'm still reflecting on it. Yeah, what is your interpretation from it? I'm not sure if you break it down the comparison. I'm just thinking that your all category is bringing in the severes with them, so it ends up, it reduces the difference if you're
Yeah, it
comparing
kind of
to the
hides what's happening with
non-severes.
the non-severe versus
Yeah,
severe.
and so you might not be able to flag it completely if you just compare with everybody.
Yeah, you're going to have a way bigger difference if you were doing all versus, or you were doing severe versus non-severe.
Yeah.
So that could
And
be
yeah, the point isn't necessarily to do like hypothesis testing between them or anything. It's just, I guess, like if I were going to go talk with the RMO, for example, and say like, hey, listen, if you look at this bar of severe patients, these are patients who are at very high risk of dying, and still, we're not even assessing them half the time or whatever. I think it kind of begs the point that, oh my gosh, this isn't just happening for the kids who with a broken arm. These are actually really sick patients. So I think it makes an argument to someone like the RMO. Is it as interesting academically? Maybe not. And
Yeah. No, I think it is. I think if you think about this as the the grounds for you to then make an argument to say, I need to intervene on this space because not doing this measurement is not helping us think about stratification. I think that's the core of a lot of the projects we're doing, like Liz project, the Presto, the TBI. So I think it's important data to be out there. So maybe just add another column here that you have severe, non-severe, and then you can highlight that. Just thinking
Okay.
about
That makes sense.
yeah, just thinking about that comparison there. Yeah, I think it's good. I think the graph is a good illustration of it.
Okay, cool. Well, let me continue for the sake of time, but thanks for all the
Yeah,
feedback to
go for it.
everyone. Very similarly, this is resources. Maybe there's a conversation that, for the sake of time, let me just continue. But this just shows all the resources that were available on the ambulance. Is there an O2 tank? Is there a blood pressure cuff, etc.? All right, now this is assessment adequacy. So this is, are we actually assessing the patient adequately or not? So these are the different elements in my REDCap database. So these are the things that we are deciding are happening or are not happening. So for example, exam, did we auscultate the lungs, which means listen with a stethoscope? Vital signs, did we check for the oxygen level, just as an example? So the question is, how do we decide if a medical escort has done a, quote, adequate assessment? This is the definition that comes from basic emergency care, and essentially says that an airway, breathing, circulation, disability, which are the domains here, assessment should be done on all caps, all patients during transport, in vital signs, including ABPU or GCS, which is a way of measuring mental status, meaning are you in a coma, are you wide awake, etc. All right, so again, these are the different domains in the clinical world: airway, breathing, circulation, disability. This is 101 stuff in emergency medicine, different elements. And so how I have defined the different outcomes for the assessment are these 4 tiers. So 0, 1, 2, 3. Level 3 is my interpretation of the basic emergency care assessment, which was defined on that previous page. It means you checked airway and breathing with these elements, you checked circulation with these elements, and you checked disability with these assessments. It essentially means you did an exam and you checked vital signs. Below that, I've created a level 2. This is derived from the pediatric assessment triangle, which is essentially like a very quick way to determine who's very sick and who's less sick. And that's based on the 3 sides of it are the appearance of the patient, the work of breathing of the patient, and the circulation. So did you do at least some assessment of those 3 domains? So the definition is here. You at least checked that the patient was breathing. For circulation, you either did your physical exam circulation or checked a heart rate or a blood pressure. And then disability, you checked a mental status. So that's kind of the extrapolated pediatric assessment triangle, meaning you did the bare minimum to at least make sure A, B, C, D are all intact in your patient. Level 0 means you did no assessment whatsoever. You were a warm body on the ambulance, did not check to make sure if the patient was breathing, for example. And then level 1 is somewhere in between 0 and 2. You did something, you did not do nothing, but you did not check all the domains. All right, and so this is the breakdown on what that looks like. Again, peds and adults. I drew a red line down the middle. This is level 0, you did nothing. Level 1, you did almost nothing. Level 2, you did the elements of the pediatric triangle. And level 3, you did a full exam and vital signs. All right, so the 3 questions that I have here, the way I currently in my head am defining my outcomes are kind of making this binary. You're above the red line you did at least a minimum assessment, or below the red line, you did not do a minimum assessment. So the three questions that I have here, move my box again, are one, this is kind of the question I was hinting at before. Again, I want to my sample to be all patients. By that I mean not strictly the severe patients. So is it kind of almost redundant to show the severe patients here if that's not really my outcome itself? Even though again it is really interesting for me to look at. To the outcome levels, do you think there's reason to distinguish between level 0 and level 1? I'm saying both of those are inadequate. The only reason that I did it that way is, again, to show that for adults, for example, 25% of the time, just absolutely nothing is being done by the medical escort, and which kind of begs the question, why are we sending a medical escort on the ambulance if they're not even going to check on the patient? And then question number 3 is the outcome definition. And the two ways that I frame this in my head is either binary, meaning you're above the red line, below the red line, or does it make sense to do this in more like an ordinal way? Like this is 0, 1, 2, 3, where there are actually like 4 different levels of outcomes rather than just 2. Those are my questions. Let me pause again and let me know, or if we're out of time, then cut me off when we need.
Yeah, just to be clear. So do you have another section after this? You do, right?
I have
Or is
section
this your
3.
last point for questions? Okay. Well, so we'll be quick and I think we'll be able to get through it. I
Great.
think that these questions are mainly like good for better for clinicians to answer or folks who've worked with this kind of data before. Personally, I like having the granularity here. But let's hear if others have input, especially our epidemiology and clinical folks. I see Emily, go ahead. And then Eduardo.
From an epi standpoint, Mac, I wonder if you could say all patients have a bar, add another bar for non-severe and then severe. So at least you get to see all three with that mix. I think because you keep talking about severe, and to me as a reviewer, if I read the paper and it was all, I would automatically say, well, is this different if the person was really sick? So I would trust your gut there on the severity stuff. I would stratify everything, even though it's a covariate, just severity. And then distinguish level 0 and 1. I mean, maybe that goes into number 3. Is it binary or is it ordinal? If the outcomes of 0 to 1 are probably not that different, like, does it really matter if you're doing not much? I don't know. I'm not a clinician, so I'll let Eduardo chip in. You might be able to combine those two. You might. Hey, Bella, Bella, look at that dog. Sorry, guys.
Everybody's working from home today because we have some crazy storms and the kids are here too. So we'll forgive you, Emily. We're on the same boat.
Okay, sorry, we got kids and dogs. I think you might have the numbers where you're going to have to combine to binary instead of ordinal, or maybe you can just combine 0 to 1 versus 2 versus 3. There you go. Sorry about the interruption.
It works.
Can I just plug in on Emily's comment before Eduardo? Just quickly, that I think it's also worthy to mention, if this is going to be the outcome of your assessment and you're trying to predict what drives this lack of adherence to what should be done and what should be measured, I think that's fine. It would be very interesting to also map how these levels are performing against overall patient outcomes in another way, because it would be an interesting framing to be able to say, if you have level 1 versus level 2, there's an incremental change that will tell you if the outcome needs to be different or not, instead of more, just theoretically looking at them. So I think it might be a different project, a different paper. I think it would be a worth data to have out there. That's it for me. Go ahead, Eduardo.
Excellent. I might have two things to reflect about here with you, Dr. Sakos. First one is, do you really think from your clinical practice that a team that performs um, an inadequate assessment in the field, for example, those level 1 and level 2, and especially level 0, which is no assessment at all, uh, are these teams really trustworthy when you think about the medical escort assistance they're giving? Because from my standpoint, I think that you could divide the level 3 against all the rest. So at least you have a team which is aware about the importance of assessing those patients in the field. And even though before that, I'm thinking that if these escort personnel is not dedicated to it, they might not be pre-trained. And even if they do the complete assessment, it's not appropriate. So that comes to my second point, which is in case you have the data for the hospital triage, we could maybe think about comparing field triage versus hospital triage. And then we assess if this is appropriate. And this is great information to know that this pre-hospital assistant is, even though it is complete when you talk about level 3 assessment in the field, it's inappropriate. So this is something we should be thinking about.
Mark has lots of
Okay,
great
yeah, thank
thoughts.
you.
If there's other
Yeah,
comments, feel free to put them in the chat. I think you can go forward.
okay, cool. I will try to be very quick. Thanks so much to everybody. All right, so this is resource capacity. This is the last part. This, I've done like a little screenshot here. This comes from pre-hospital emergency care from the WHO. And essentially, this is a list of everything that should be on, you see all caps, bold, all ambulances. So this is for this next section. We want to find, are the ambulances that are coming to KCMC, are they resourced or not? And so I've defined resource to be if all of these are present on the ambulance. These are the list of things that we're looking for that are relevant to trauma, that that are part of our red cap, and that are also supposed to be on all ambulances. IV fluids is not listed as something that should be on all ambulances. It's listed under just advanced ambulances. So the reason, to my understanding, why it's not listed to be on all ambulances, I had a conversation with one of my mentors who's on the inside of some of this, and he said due to storage and expiration limitations, and then ordering, meaning, for example, if the medical escort, whoever it is in some country, is not able to ask for a medication themselves without, for example, a doctor's order, and the doctor is not available, something like that. So IV fluids is not contained on this list. So again, the different outcomes, the way that I've defined this, for the first option, this is very straightforward. An ambulance is resourced or it is not. It has all of the different resources listed in the previous slide, or it does not. Another way that I thought could be interesting, and would love your feedback, is to add another tier. This came from some of Catherine's advice to me to say, don't just follow the checklist in front of you, think like clinically what really matters. And so I added this extra level, which I've defined this way. Down at the bottom right, resources are available to intervene on life-threatening cardiopulmonary derangements. So maybe you don't have your stethoscope with you, but you do have these things below. So for respiratory failure, again, the A's and the B's, following this kind of ABC framework from before, you have oxygen and a way to give it. You have a bag valve mask and a mask, which is a way that you can breathe for somebody if they're not breathing on their own. And then for shock, you have IV fluids. So essentially, it means, hey, we're asking medical escorts to examine patients to look for these derangements. Then do you actually have something that you could do if you have an abnormal finding? If I do not include IV fluids, it kind of begs the point of why are we asking the medical escorts? Why are we, quote, requiring them to check circulation if there's nothing necessarily in the ambulance to do about it? This screenshot at the bottom right comes from another WHO resource that came out recently. And I just want to show that if a patient has shock, the next step is give IV fluids. I know this is much simpler than what happens in a real emergency room. This is the recommendation. And it says specifically this can be done by basic and advanced providers. So it seems that there's a bit of a contradiction here where they say WHO says all ambulances do not necessarily need IV fluids, but they do recommend giving them to a patient with shock. So anyway, I don't know exactly how to, I'm going to have more conversations offline about this IV fluid question, but I guess maybe for this conversation, do you think that it makes sense to include this extra level 1 tier, or would you keep things simple and just do resourced versus under-resourced option 1?
Again, I'd have to defer to clinicians or the literature. Eduardo, where the rest of us are stumped. I don't have an answer.
Yeah, I'll be the same. I don't think I can
Can you listen to me?
connect much here, Mac. Go ahead, Eduardo.
Okay, thanks. Again, Mac, this is what we were talking about the last slide, the last question you had about when you're tiering. And so, do you think that in your clinical practice, from what you see in your experience, a minimally resourced ambulance versus an under-resourced ambulance would be very different from a resourced ambulance? Only thinking about from the standpoint of the resources themselves. I'm not even talking about the people who are there to use these resources appropriately, which we've seen already that there are probably people not trained enough because they don't assess patients and maybe they will not use all those resources. But if you think that this minimally resourced is actually different from the under-resourced and from the resourced, you could think about leaving that. If you don't think this is, which is what I suspect that will happen, I would just leave resource versus under-resourced. So either you have everything, or if you have anything which is not full, I would just leave it out from the resource category and have only a binary one.
Yeah, I mean, I think to me there is some notable distinction. I mean, if there's a big difference between having an ambu bag and not for a patient who's not breathing, which seems very different to me than having a stethoscope or not having a stethoscope. But those two would fall under the same category of under-resourced. So I guess the only reason I thought to do it this way is to make the distinction between kind of a technicality to some degree of not having your stethoscope, you left it behind, versus you actually can't help a patient who's dying in front of you, sort of thing. And again, yeah, if people aren't trained adequately, there's that. But I think this is trying to answer a bit of a different question that, okay, assuming we train people, whatever, to do an adequate assessment, then what is the situation with resources? Is that also an issue that we need to solve, and to what degree? That to me is why maybe it makes sense to distinguish them, but I could go either way. Anyway, these are tough questions. And Eduardo, maybe if you're up for it, then I can share my email and we can reach out and find a time to talk some more. Maybe that's the best place to leave this for now.
Sure, I'd be happy to talk to you.
Awesome. Thank you so much. And then maybe just for the sake of time, I kind of agree with Eduardo's comment. Currently, I'm leaning toward putting adults and peds together. And then maybe the last question I'll just ask for people to weigh in on. Does it make sense to put all this in one paper, or is the resource and the assessment two different papers?
At first, my reaction was, as I said in the chat, personally, I typically tend to lean towards splitting. But then having seen kind of what the meaning is of these things, I rather like keeping them together. But as I also commented, it's also depends on the target journal in terms of word limits, and just how the editors or reviewers are going to respond. I'd love to hear other perspectives on those questions.
I'm surprised that I'm about to say combine peds and adults, but I agree with that to not stratify. I'm not sure you have the numbers, but I also think the same in this context, the same ambulance is going to carry both. You're not going to have peds specific, and um, so I would say keep it. I actually think this makes one good big paper, and it goes to the story because I feel like if you compartmentalize too much, you're going to tell half the story in one paper and then wait to tell the other half in the other. Um, that's my gut. I think you can do it without stratifying too much.
Yeah, at first, everybody I was speaking to said, "Oh my gosh, you have to keep them separate." And now I've had the conversation again, and everybody seems to lean toward putting them together, which is also my feeling for the exact reason that you mentioned. Cool. Well, I think I've taken up more time than I was allowed. So thanks to everybody. I really apologize for the delay. Thank you so much for your feedback.
No worries. Everybody join us thanking Mac. This was really great. As I said in the chat too, this is going to be, I don't know, whatever his name. It's really important work. I think there's a lot of people who are going to want to see these results. And so I'm glad to hear that you guys will be submitting to AppSim. There's definitely a lot of folks at AppSim across the continent who would be interested in seeing this work, THS and other venues for getting this work out there. So uh, hoping to see more. And as Max said, he'll come and come back in about a month to talk some more. I would also like to really thank folks for their inputs. I'm glad we have Eduardo here, as I said, Joao, Emily on the epidemiology side, Natan with some more clinical insights in the chat.